Okay, so I continue what Professor Sada introduced, the autofluorescence. And then actually, I like autofluorescence, and I like actually Vas already introduced. I'm a multi-imaging supporter. So I think it's the combine all the information that we can get from all the imaging modalities is very useful to do a right diagnosis. And speaking about autofluorescence, we know that the most important fluorophore in the eye is the lipofuscin that is in the RPE cells. And the lipofuscin is actually be visible in if you use a autofluorescence microscope, and these are the granules presence of lipofuscin in the RPE. Now, one of the things that we know is that more we grow, more we glow, because in fact, the young subjects has less lipofuscin, even if they started to build up when we are 6 months old, and we actually see an increasing with age. And as you see in this flat mountain of RPE cells by Charlotte Remy. So lipofuscin is related to the shedding of the disk of the photoreceptor, and the incomplete digestion, it's creating the lipofuscin, sorry. And, but the other possibility to create lipofuscin is a melanolipofuscin, that it's coming from the degradation of melanin granules. Now, when we speak right now about autofluorescence, we can actually see a series of instruments that can get an autofluorescent image. And you cannot probably see that there is I put a blue background and a green background and a pink background. And these are the 3 different types of autofluorescence that you can get. The blue autofluorescence, it's done with the spectralis, with the NIDEC, and with the EIDON. Then we have the green autofluorescence that is obtained with the Optos and all the other fundus camera. Now, why we cannot get a blue autofluorescence with the other instruments and just with all these 3? It's related to the fact that one of the biggest fluorophore in the eye, particularly if we excite with a blue light, is the lens. And more, the lens, it's a yellow, more, fluorescence it is. And so if we flash all the lights in, and we got all the light that comes from the eye, we will not see the fundus, because the main fluorophore is coming from the lens. So because of that, if we want to get a blue autofluorescent, we need to have or an IOL or a confocal aperture. And this is why you see it's not related to the scanning laser, but just to the confocality. And the EIDON is a slit scanning confocal LEDs instrument. And the difference is that instead of having a pinhole, you have a slit lamp. And the scanning laser is also from Optos, but since it's not confocal, it's not able to get a blue autofluorescence. And what you get is a green autofluorescence. And here, just to show, the different type of fluorescence that you see. And the big difference, once you get, it's the dark spot in the center of the fovea. And the center of the fovea is due to the yellow pigment, that it's the lutein or pigment, or the macular pigment, and so it's a dark spot. And more you move to a green light, autofluorescent, you see that it will disappear. Now, why? Because I said, if you have a macular pigment, it's yellow, and you use the blue light, it's absorbed. And of course, you can actually have the blue and green taken with the same instrument, with the spectralis, and you see the dark spot here that is not visible here. And of course, if you take also a patient with a retinal pigment epithelial detachment, the green and the blue again differ from a spot there. Why blue is important in clinical practice? You know, you heard about the fact that if you have a geographic atrophy and you want to see if the fovea is involved or not, because it's a dark like the surrounding area, you probably have to combine. But and you have actually also infrared in the EIDON, so you can actually use it for that. But the most interesting part is that when you have a blue light, you actually see the macropigment. And there are a series of diseases where you actually, it's important to detect if we have a macropigment or if the macropigment is displaced. For example, here you see an old picture that I have from the same patient taken with the Heidelberg and the two Fundus camera. And these are green and these are blue. And you see that you actually see very well the cyst just because the macropigment is displaced. And so you don't see anymore the stop from the macropigment, but you see the fluorescence that comes from the RPE. Here, since you don't have a mask of the macropigment, you're not able to detect the difference in the presence of the cyst. And the same is, for example, for pseudo-hole or lamellar hole. You know, the fact that sometimes also OCT is not able to detect. If you have a lamellar hole, you have, you don't have anymore some tissue, and the tissue has also the macropigment. So you see, if you see a fluorescent, you have to say that that is a lamellar hole. If you still have the boundaries of the OCTs looks like, a hole, a lamellar hole, but they still have the dark spot in autofluorescence, then it's a pseudo-hole. So it's very useful for that. Here another example of two different wavelengths. And you see the dark spot and the absence of dark spot. And here another one with the cyst visible here and not here. Now, the other thing I said is the confocal aperture. And the confocal aperture allowed you to see the layer that you are interested in, and you don't collect the lights that comes from the surrounding area. And that, again, it's important if you want to take out the fluorescence that comes from the lens. And here in another example where we actually see the confocal, and where you look at this pigment, this is a melanolipofuscin, you see, but it's a different level comparing with the increased fluorescence in this vitelliform lesion. You see, if you take a normal, not confocal, you will not see. It's everything has the same fluorescent. The other advantage is that you can go through such a small pupil and get a color, an infrared, and an autofluorescent. And you see, you actually, you have to remember that it's only one shot. It's not a mean of images. And in fact, for example, if you explode the images, you actually see very well the details. But remember, it's a 60 degrees where you can go and very, out to 20, 30 degrees. Now, this is the same patient taken with the Heidelberg, and you see it's a mean images. And here is the same with EIDON. But what about if we take one image of Heidelberg? This is the single image. And you see that due to the fact that it's more confocal, you lose light. So you need to have a series of images to average to get a decent image. Now we can go through some cases. Here another atrophy where you actually probably see the choroidal vessel over here with different type of fluorophores. Here it's a central seroscleral retinopathy. Another one with some gravitational things. Here it's a patient with treated with diabetic retinopathy. This is a Stargardt patient, and you see very well. Again, it's a 60 degrees, can go through a small pupil, and The interesting thing is that it's one shot. And vitelliform lesion, you know, best lesion is a Stargardt patient with atrophic changes, and another Stargardt, retinitis pigmentosa. So in conclusion, the big advantage of the EIDON is a white color. It's not false color, it's not multicolor, it's really a white color. Then you have the fact that it's, you can get an infrared image, very useful. You have to get used, but you can actually use many times. And then you have the blue autofluorescence that in a clinical practice, I think, is very useful to do a series of differential diagnoses. Thank you.